Good afternoon. Welcome back to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Welcome to all of our friends here at UCSF and in our health network. And as usual, we will put this up on YouTube tonight at about 7:30 or so. You see the instructions there on your screen. Put your Zoom window in full screen mode. If you have questions, type them in the Q&A box, and we'll try to get to as many as we can. My colleague Quinny Cheng is monitoring that. Closed caption is available. Click on Show Subtitles to do that. So looking forward to the session. I'm going to go quickly through the introduction because it's a very full session. We find ourselves at a remarkable time in the pandemic with a lot of optimistic news. The cases are coming down rapidly in San Francisco, in California, in the United States. Vaccines are rolling out, and after the initial bumpy phase, things are starting to get somewhat better. We have a new administration in place and a whole lot of whole change in the way we are approaching COVID at a national level. So all that is hopeful. On the other hand, we have these new variants entering our world and certainly around the world. And so we're going to talk about all of that today with four terrific speakers and a lot to do. We will go till about 1:15 or so. Simply couldn't pack this into an hour. First speaker is, first we're going to talk about vaccine distribution. We've been doing that for the last several weeks, talking about distribution at UCSF, but we're going to take a slightly different tack today and talk about distribution throughout the city of San Francisco. And the speaker will be Dr. Susan Phillip, who's the acting health officer for the city and county of San Francisco. Susan's been part of our COVID response since the first days of it. She previously served as deputy health officer and director of disease control and prevention in the population health division in the Department of Public Health. She also, I'm pleased to say, is an assistant clinical professor in our own division of infectious diseases here at UCSF. Susan will speak first about the San Francisco vaccination program and how it's going. Then we'll turn to George Rutherford, who everybody knows by now, who will talk from about 12:17 or so to 12:30 about the state of the pandemic, including the improvements in cases, but some of the worrisome issues that we still are seeing. And then we'll switch to, for the last 40 minutes or so, talking about the variants. And for that, we've got Shane Crotty and Sir Patrick Vallance. I'll introduce them in more detail when we get close to that segment, and George will join us as well. So from about 12:30, 12:35 until 1:15, we will talk about variants, the biology and immunology of them, epidemiology, and with Sir Patrick, we'll also talk about the experience in the United Kingdom, which of course has been hammered by that at least one of the variants. So a lot to do. Really looking forward to this session, and so let me turn it over to Susan Phillip, who will take us through what's happening with vaccine distribution in San Francisco, and then we'll have a short Q&A, and then we'll move on to the other parts of the session. Susan, thanks for being here.
Thank you so much for the invitation to be here, Bob. Really, really happy to join you, and happy to give an overview of how we've been planning for a vaccine rollout in San Francisco. And I want to preface this by saying, like so many other places across the country, the problem right now is supply. So we don't have adequate vaccine, and what we're getting is very intermittent and erratic. So the supply issues are real and they're very present. But we have been thinking very carefully as a city and working across the city with so many healthcare partners, including UCSF Health, to really serve the people of San Francisco as well as possible. So we are ready when the vaccine supply increases. Could I have the next slide, please? So our overall strategy is designed to get us to a place as quickly as we can have the supply of vaccinating 10,000 San Francisco people in San Francisco per day. That includes both residents and people that work within the city. And to do this, we knew that we could not do this alone as a city entity, although we have many people from not just our Department of Public Health, but our Department of Emergency Medicine and many Department of Emergency Management and many other groups also leading this work. We knew we had to get involvement of communities, particularly those most impacted, and also our healthcare system partners. So we have largely three strategies. One is for high volume vaccination sites. Another strategy, recognizing that that will not work for everyone, but that is a way to get large numbers of populations vaccinated very rapidly. The second way is to work with existing clinical sites, existing clinical partners and community partners who are known and trusted by communities to get vaccine into locations that are a little bit closer to people. And then there's a component where mobile vaccination may also play there as well. And then the third is to work with commercial pharmacy partners to make yet another avenue to get people vaccinated. And so in doing this, we're starting out slowly, we're building this infrastructure, and our eventual goal, as we said, and as voiced by Mayor London Breed and by our DPH director, Dr. Grant Colfax, is to get to 10,000 people a day and to do it in a way that is really user-friendly, meaning that eventually we want to get to a point where people can access a notification system, which is live now, but also scheduling and registration system from a central point for any of these sites. And furthermore, that these sites are going to be agnostic to the usual source of your healthcare, meaning that even though a site may be run by UCSF Health or by Kaiser Permanente, anyone is able to access that site once you meet the eligibility criteria, once we're at that stage in the vaccination tiers, which are really run and controlled primarily by state guidance. Next slide, please. So just to talk very quickly, I think I've given you the sort of the general high level points about this, but for the high volume sites, this is a partnership. We are working with health system partners who are such an essential piece of making sure that we can do this. The sites, again, are going to be provider agnostic, and we feel that that is a critical and a distinguishing feature of our plan in San Francisco. And we in DPH are coordinating some of the vaccine supply, although a lot of vaccine is coming directly to the large health systems as well from the state, and data collection and feedback. So this is a true partnership between health systems, between the city, and between our community partners. So we have already launched our first of these high volume sites at City College of San Francisco, and that is in partnership with none other than UCSF Health, and it has gone very well so far. We also have sites planned and announced for Moscone Center, and then for the San Francisco Produce Market in Bayview. These sites were selected to be close to the southern and eastern parts of the city, which have been most hit by this pandemic. And so they were picked very deliberately in discussion with community. And you see all the partnering health systems there. Next slide, please. So that's the high volume sites. That is where we're going to get very high throughput of large numbers of people in San Francisco through and vaccinated. But then we talked a little bit about understanding that that approach may not work for everyone. There are lots of people who don't have cars, who don't have an ability to do these high volume drive-through sites. So then we spoke about the community vaccine access sites. And this is really to work on equity and to have that focus of equity, which we have had and spoken about throughout the pandemic. And again, there's overall coordination by DPH and the COVID Command Center, and all of the city agencies working on COVID response are part of that as well. And this is going to really do outreach and offer vaccination at culturally and geographically appropriate and accessible sites with our city's support as needed. And again, on the right, you can see the collaborators there. And we are in the process of working on this and then expanding our scope and rollout over the next coming weeks. Next slide. And then finally, for broad access throughout communities, throughout the city, this approach is to work with Walgreens and Safeway, existing pharmacies, existing sites that people already access within their neighborhoods. And this is, again, going to be another key site for people who cannot or do not want to access the other two avenues for vaccine. And these pharmacies have historically been a key location, as we know, for other vaccinations, such as flu vaccine. And so we'll be able to build on that strength that they have to administer and record vaccine doses. So the federal government is additionally working also with pharmacy partners, particularly to make sure that residents of long-term care facilities are fully vaccinated, as we know that they are a group at very, very high risk of death from COVID-19. So next slide, please. And we are also committed again to collecting the data. That is our function as a city and as a Department of Public Health. And we are making this available to the public on a dashboard that can be accessed through the SF.gov website. And here we will be tracking how many people are vaccinated in total and how many San Franciscans have received a first and second dose. And here you can see, our current data, and we're still working, as you can imagine, getting the data from all of the health system partners and everyone who is providing vaccine throughout the city, not only at the sites that I just mentioned, but within the health systems themselves, such as UCSF Health, is a complex thing. But we are working on it. We are so excited to have the partnerships that we have with community and health systems. And we think that this, again, is going to be the most user-friendly and most accessible way to ensure equity and ensure that we get vaccine out as quickly as possible as soon as we get it. Next slide, please. And so this is a picture from City College, from the great partnership with UCSF Health and the way in which we are operationalizing the vision that we have of equitable access for vaccine and enabling vaccination as quickly as possible for as many people in San Francisco who want it. And I think that is my last slide. Thank you.
Great, thank you, Susan, really appreciate it. In terms of, we've heard a lot about the supply bottleneck, but it's the surprising thing for the past month has been the distribution bottleneck, and in California being among the lowest percentage of vaccines that were on hand that had been distributed. Is that getting better? And how are we doing in San Francisco compared to California and compared to the national average in terms of distributing the amount of vaccine that we already have?
Yes, we are doing better in San Francisco than in other places. And I think what we have learned is that in some cases, it's a data issue. It's not that vaccine is actually sitting on the shelf, but the systems that are in place, the systems that were in place prior to COVID and the California state system called CARE, it's challenging to get data in and to get data out. And so there's a balance between doing this as quickly as possible, which we want all of our providers to be able to do, and them recording every single dose in CARE in real time. And so the state is recognizing this and trying to work on different ways of working with third-party administrators or others. So we're going to be hearing more news about how the state is pivoting to try and increase their understanding of the true distribution and administration of vaccine that they have gotten allocated from the federal government and then sent out to the 58 counties.
And how confident are you about supply? So as we get better at getting it out, I assume then we will hit that supply bottleneck. And part of the bottleneck has been the amount of vaccine, and part of the bottleneck has been just not being sure what's coming, which makes it very hard to plan. So from what you've been hearing and seeing in San Francisco, how do you think we're doing and are going to be doing?
Well, I think that is exactly right. It's the uncertainty, it's the boom and bust that we have really experienced with vaccine that makes it incredibly difficult to plan and to plot out appointments and schedule people in. And what we're hearing from the state is that we will have some boost in our doses of the Moderna vaccine, especially about a 15% boost over the next few weeks, which will be good. But again, it's going to take a little while. What we're really looking for is that federal leadership to smooth out the allocation, to all of the states. And with the data issues that everyone is working on statewide, we feel that we'll be in a much better position in a few weeks in terms of vaccine rollout and understanding how we're doing and correcting any areas where we need to.
Great. One of our viewers said, and I'll expand the question, with regard to equity and communication, how can people who don't have or use computers? I just found out I'm driving a relative for a vaccination this weekend. How about people who don't have transportation? Are we thinking about different modes of transportation, Uber and Lyft, or public transportation to help people get to these appointments?
Absolutely. I think that's such an important point. And that is exactly why, in San Francisco, we're thinking of multiple approaches, knowing that one size doesn't fit all. And some people don't have cars, and some people, those high volume, high throughput car-based sites are not going to be right for everyone. We are moving to trying to eventually get to a single source where people can access either by their computer or by calling to have assistance with getting scheduled and set into one of the sites that would be best for them. And so I think there's a lot of work and thought going into that. And we're getting input from communities themselves, which we think is the right way to do this. What would you like? What would help your more vulnerable older adults and others get vaccinated? And I know that we're going to have to keep adjusting our approach as we go. So we're starting out with an idea, knowing that we're going to have to pivot as needed. And that's what makes the partnerships with the health system so great, because we know that we have this strong established infrastructure that can do the very high volume, high throughput vaccination. And that allows BPH to work with our community-based organizations and other partners who really know how to focus on the equity piece and get that part of it done. So absolutely, we're thinking about access for everyone.
Great. Maybe my last question is, and I know the city only has limited control over this, one of the real challenges is the prioritization schemes. And it's one thing to say we're doing healthcare workers and another thing to say we're doing people over 75. It's easy to measure and easy to sort out. As you move toward more granular categories, it gets trickier. And whether it's proving that someone is a grocery store clerk or what is a pre-existing condition that counts and doesn't count. So how are you grappling with, as we move to more complex parts of the algorithm, how are you grappling with the tension between perfectly reasonable ideas around equity, but also sort of they add some operational challenges. They make it more complex. How are you thinking that through?
Well, I want to preface by saying that in San Francisco, we're still firmly within the realm, the phases and the tiers of healthcare workers and people that are 65 and up. And that's because we have we're lucky, we're fortunate to have such a large population of healthcare workers here to take care of our residents in San Francisco. So we are not yet to some of those other tiers where we're thinking about how we would do it. This is an active point of discussion and change at the state level as well. So there are ongoing discussions with the California Department of Public Health and the governor's office about exactly how we do it for the reasons that you just said. And so we are thinking about age, because we know in San Francisco as elsewhere, the people that are 65 and up are 83% of the deaths from COVID-19. So age is always going to be a focus, but we also know that equity is so important. So these discussions are still ongoing, and we know it's going to be very challenging to balance for the reasons you just said.
Great. Thank you for coming on today, and thank you for what you're doing in this. As I've said to our folks at UCSF who are doing the vaccine allocation work, if you look up thankless job in the dictionary, you probably see this job, and I'm sure you're getting calls from everybody in the universe. But appreciate the thought you're putting into it and the partnerships you're creating, including with us. And good luck. Let's keep on getting it right. Thank you.
Thank you so much. Good luck to all of us. All right. Thank you.
Yeah, exactly. Okay, let's move on to George Rutherford. And I could read George's intro, but I've done it 37 times, so I won't do it again. You know he's a professor in our Department of Epi and Biostatistics. What I do have to show today is I received a T-shirt from one of the primary care groups in San Francisco called Private Medical Group. And they are such George groupies, and they're not alone, by the way. They sent me this T-shirt. It says, wear a mask, people. There's George looking very stern. And then on the back, it says, in George we trust, which in fact we all do. So how's that for an intro, George? You're on.
Well, thanks, Bob. Yeah, you can, but by the way, that go to my Profees account, not Bob's. If anybody wants to buy them, let's just figure it out. I wanted to start out by talking about the situation worldwide. We're continuing to see the growth of cases, although you may be seeing a kind of an end of this wave here, with most of the cases being in the Americas and in Europe. There have been almost 100 million cases reported. This was as of January 24th. WHO puts out data weekly, with 4 million new cases last week, 2.1 million deaths, and 95,000 additional deaths last week. The U.S. leads the pack here in terms of cases in the prior week, followed by Brazil, the UK, Russia, France, and Mexico. And I think this is something to be really cognizant of, is that right on our border, there's still large outbreaks going on. May I have the next one, please? In the U.S., there have been 25.6 million total cases. We're averaging about 160,000 cases a day. You can see that we really are on the downslope of this third wave of the epidemic, but we're not all the way down yet. It has not the mortality has not caught up. We're continuing to have more than 3,000 deaths per day. The cases are falling in all the states except North Dakota, South Carolina, and Virginia, and Hawaii is the only state that really hasn't surged or is not recovering from a surge. In December, COVID became the leading cause of death in the U.S., and for 7 days in December, and I think this is astonishing, and 16 so far in January, there were more deaths in the U.S. from COVID than from cardiovascular disease and cancer combined, which is about a 3,300 death threshold. The next one, please. Here you can see where there's been transmission recently. You get this sense of the Mid-South, and much more clearly in the western part of the country, and particularly the Southwest, where there is ongoing transmission. And you can see some big counties in California, which include Inyo and Riverside. Those are the big dark ones. The next one, please. In California, we're also on the downslope of this third wave. We were totally at 3.2 million cases. We're averaging a little over 20,000 cases per day, but yesterday there were 18,000. This bespeaks the decline. There have been 38,991 total deaths, with 720 yesterday and a 7-day average of 561. Deaths have not started to go down yet in California. Deaths typically, looking at the other parts, have lagged about 3 weeks behind the falling case counts. Where is this all going on? It's all going on in Southern California, with huge numbers of cases in Los Angeles, Riverside, San Diego, San Bernardino, and Orange. But you can see they're starting to fall, especially in Los Angeles. And that raises the question about whether naturally acquired immunity is kicking in, given that they're probably looking at 20% of the population that's been infected in Los Angeles County. Elsewhere, we're in Santa Clara and Alameda, but even Ventura County, which is a small county, but right next to Los Angeles, has a ton of cases, as does Kern, which is over the hills, but still kind of contiguously part of the Los Angeles basin. The next one, please. This is to convince you that these declines are real. We have a decline in the positive test rates. We have a decline in hospitalizations, and we have a decline in ICU admissions. The statewide case rate has fallen by 33%. Over the last week, hospitalizations have fallen by 22%. And deaths, however, have not fallen, and unfortunately, they've risen by 14%. Overall in the state, the effective reproductive number is 0.81. And I note that the ICU capacity remains at 0%, but that's a very kind of, that's a nuanced metric. The next one, please. Here in the Bay Area, we've had 365,000 cases. You can see we're clearly on the downslope here, but still are having a couple of thousand cases a day. There have been 3,998 total deaths, with 85 on yesterday. And those are not yet decreasing either. If you look across the 9 counties in the Bay Area, you can see every county has declining case rates. Santa Clara and Alameda, which have the largest case numbers, are falling among the fastest. If we look at the state's tiering system, this is TIER system, you can see that all the counties are well over the 7.0 cases per day, per 100,000 cases per day, which would get us to the purple tier, get us from the purple tier to the red tier. But the good news is that the effective reproductive numbers are all very low, and only one in Alameda is 0.90 or above. And the positive rates, which I put in the color coding, you can see San Francisco would actually be in the orange if we only looked at the positive test percentages, whereas the others, several of the others, including Santa Clara, Alameda, San Mateo and Marin in the kind of close in Bay Area would be in the red tier. The next one, please. Overall, this is your test for California geography. You have to name those 4 counties. I'll give you a hint here. But this isn't great, but it's a lot better than it was. The ICU capacity is this complicated metric that the states put forward and has changed at least once. And you can see this big surge in the Bay Area that jumped up over the weekend. So the ICU capacity is really talking about the proportion of licensed ICU beds, adult ICU beds, no neonatal. They had got rid of the neonatal beds at one point in time. ICU beds plus surge ICU beds. That was what changed over the weekends. They added the surge ICU beds into the denominator that are occupied by COVID-19 patients in excess of 30%. So 0% means that more than 60% or more are occupied by COVID-19 patients. So it's a little misleading. The numbers are a little misleading, but that's what they mean. So statewide, more than 60% of all beds are occupied by COVID-19 patients. As you can see from some of the earlier graphs, that's starting to fall. The next one, please. Now, nationally, we have this came out on Wednesday, the first full day of the administration, and it had these 7 chapters and kind of aims. And I think it's really telling to have the first chapter be restore trust with the American people, the second on vaccination, the third about mitigation measures, the fourth about the Defense Production Act, the fifth about schools. And CDC put out a big editorial yesterday in JAMA about schools reopening, and they saying that they thought the case was compelling and that schools should reopen. Protect those most at risk through advanced equity. And advanced equity, as Dr. Phillips talked about it at length, and restore the U.S. leadership globally and build better preparedness for future threats. So I'm on board with all 7 of these. Okay, the next one, please. Now, everybody likes to talk about vaccines. So here are the 4 hot questions about vaccines. Okay, the next one, please. The first one is what other vaccines are going to be authorized in the US by the summer? And I think these are the 3 most likely to come down the line. The AstraZeneca one, which is an adenovirus vector, chimpanzee adenovirus vectored vaccine, which has already been widely used in Europe, in South Asia, and in Latin America. Another is the Novavax, which is interesting. That's a protein vaccine as opposed to an adenovirus vectored vaccine. And that is in phase 3 trials in both the UK and the US. And then the Johnson & Johnson vaccine, which when Dr. Fauci was talking yesterday on CNN, it sounded like these results were imminent in the next, he said by the end of the month. And I think he meant by the end of January, which since it's January 28th, that's kind of a big claim, but maybe he meant February. This is a single dose adenovirus vectored vaccine which has a lot of kind of stability that's very kind of consistent with cold chain requirements. The interesting thing about this is that the phase 3 trial that underlies this approval, and this is also the Janssen technology, is being conducted in, among other places, Brazil and South Africa. So we may get a shot at understanding at how well this vaccine works against those variants. The next one, please. So the next thing is, how well does a single dose work? If you dig into Moderna's filing with the FDA and go to table 15, which is practically at the back of the efficacy section, there's this table. And this is looking at people who had a single dose and were followed for a median of 28 days. And so this is what they calculated the protection was in that short period of time. And it was overall 80.2% was the vaccine efficacy. But if you waited for 14 days, which is now we're talking about days 15 through 28, okay, so it's a really narrow window, the vaccine efficacy went to 92.1%. Understand this is a non-random sample of participants. So but that's what that's published. Okay, the third one, now we're really out. The next one, please. we're really out on the kind of the tenuous limb here. This is, can vaccine prevent asymptomatic infection? And to dig at this question, you have to get into the Baden's article, the New England Journal article about the Moderna vaccine, and get to the last table in the supplement. And in that, they looked at the same situation, people who had gotten one vaccine. And this was looking at the period between the time they received the first vaccine and they were waiting for the second vaccine. During that time, there were a total of 332 infections in the placebo group and 35 in the vaccine group, which they calculated as an efficacy of 90%. However, if you've taken epidemiology at Berkeley, like I've taught before, you know how to do vaccine efficacy measures. And this doesn't have the sophistication of knowing what the person years are. But if you pull out the people who actually got clinical COVID and then ask the question, you could see that 39 people out of the placebo group got had a positive viral culture, but were asymptomatic, but not culture, positive PCR, but were asymptomatic, and 15 in the mRNA group. And if you go through and do the math, that comes out to a vaccine efficacy of 62.1%. Understanding that's within a 28-day follow-up period. So it hardly bespeaks the long term, but it does give you some pause. And the next one, please. And so I'm teeing this up for the other speakers. How well does the mRNA vaccine work against the variants? So I'll stop there and happy to come back and answer questions on the panel.
Great. Let me throw one question out for you now. George came in from one of our viewers, and I think one thing everybody's asking, which is, what's your opinion of the governor's decision to partly reopen based on the current status? Was that the right call?
Yeah, probably. It's there's not a playbook, there's not randomized control trials that say outdoor dining, thumbs up, thumbs down. We're working with the city to put together a series of case control studies that can really examine those questions in greater detail. But I think that it's everything's a trade-off, and understanding the projections for ICU capacity, I think you could let your foot off the brake a little bit. But understanding you're going from a statewide stay-at-home order, except for the northern tier of counties, to the purple tier, which is almost as restrictive. So it's not really letting that much off the brake.
We'll bring you back again in a couple of minutes. Let's introduce our next speaker, Shane Crotty. Shane is professor at the Center for Infectious Diseases and Vaccine Research at the La Jolla Institute for Immunology. His lab works on vaccine strategies for a variety of pathogens, now not shockingly, including COVID-19. And he's really big and a national leader in helping us think about the molecular biology and virology and vaccinology of all this. And proud to say he received his PhD in molecular biology and virology from UCSF. So Shane, welcome back. Structurally, Shane's going to talk for about 10 minutes, and then we'll bring on Sir Patrick Vallance, the Chief Scientific Officer of the UK, and we will all talk for the last half hour or so about the issues largely surrounding the variants. So Shane, you are on.
Great, thank you. Yeah, so I am going to do my best to quickly summarize the immunology of the SARS-2 variants and how it relates to vaccines. Oh, just so George mentioned J&J News. So a number of people are expecting by the end of this month, by February 1st, for there to be an announcement, just based on the overall schedule of the clinical trial, not based on any other information besides that. So that's where that came from. So, all right.
You said February 1st. Do you mean February 1st or January? The end of January or the end of February?
The end of January, by February 1st.
By February 1st, got it.
Yeah. And again, they don't have to, but that's basically the earliest they could based on the overall clinical trial schedule. And so given how many cases there have been, the expectation is they would have enough data by that point to make a filing. So that's where that's where those statements come from. So the variants are complicated, and the immunology is complicated. I'm going to try and give, again, a very quick summary of this, high level, and cover the key concepts. There's more data coming out every single day on the immunology of these variants. So I'm not going to, so I'm going to cover what I can, summarizing what we think we know. The executive summary of everything I'm going to say for anybody has to jump off and go save lives or whatnot, it is really that the UK variant is unlikely to be a concern for COVID vaccines. The variants circulating in South Africa and Brazil are at least some cause for concern, perhaps with a measurable effect on vaccine protection, i.e. Symptomatic infections, but that the vaccines will still almost certainly protect from serious cases of COVID-19, okay? But given that there's some immunological reasons for concerns, it'll be wise to develop updated vaccines that could better recognize these particular variants that are sort of different than what's been seen in the past. And indeed, already Moderna and Pfizer have announced in the past few days that they are going to do that, going to explore those as quickly as possible. So to get into it a bit more, immunologically, how hard is it to protect against variants? Why are variants interesting immunologically? Broadly speaking, if this is the spike protein, the green and the gray are antibodies binding. So the RBD domain, that's the target of like 90% of the neutralizing antibody responses people have. Okay, so that's where a lot of the interest and focus is. And then there's this N-terminal domain that's about 10% of neutralizing antibodies on average in people. The UK variant has only one point mutation up in this RBD domain. And so based on lots of previous data about the breadth of human antibody responses, it wasn't expected that single point mutation would be enough to significantly impact the overall antibody response. And indeed, now in the past week, maybe 2 weeks, most studies examining that have observed no or modest impact on neutralizing antibody titers in people for recognizing the UK variant. So that's consistent. It makes sense. The UK variant definitely is a variant of concern because it is more transmissible, but it's not a concern for vaccines in terms of it doesn't look like it escapes. Okay. The other variants, the South Africa and Brazil variants, to use the colloquial names in the interest of time, are somewhat different because it's not that they have one mutation, it's that they have multiple mutations. And so here's another molecular graph of the spike protein, and here's this RBD domain. If you want, you can think about this like a shoe, okay? So if the RBD domain is a shoe, and you were going to pick up the shoe with your hand, right? Your hand grabbing a shoe is about the size of an antibody, your hand being the antibody grabbing something. So this would be the top of the shoe, one side of the shoe, and the other side of the shoe, okay? And these are footprints of different antibodies. And basically, there are a bunch of different ways. There are like three main surfaces, the top, the bottom, the top and the two sides. The bottom isn't accessible. And antibodies recognize those surfaces in different ways. So like your hand grabbing a shoe, there are a bunch of different ways your hand could pick up that shoe, okay? But there are some favorite spots. And overall, one of the good news aspects of immune responses to this virus over the past year has been that this part of the virus is easy to recognize. There are lots of different antibodies that can recognize it. But when looking at these two variants, they do have multiple mutations on the surface there, and that might make it more difficult for multiple antibodies to recognize this. And so that's what there's been a lot of data on in the past week or so, okay? And so I'm only showing bits of data from a couple of papers. There are a bunch of great labs who have done really good work. Here's a table from a preprint by Nussenzweig and his other collaborators at Rockefeller. There's also similar data from Penny Morris that with monoclonal antibodies, when they've used that to map the surface of these mutants, there is significant immune escape. So in red are sites that are mutated in the South Africa variant or Brazil variant. And they have a significant effect on those monoclonal antibodies, indicating that these surfaces, the places on the RBD that the antibodies like to bind, a significant number of antibodies now have difficulty binding to the mutants. Okay. Interestingly, 2 of the mutants also significantly improve the binding affinity of the viral spike to the receptor ACE2, potentially making the virus more infectious. Monoclonal antibodies are nice for mapping, but what we really care about is what's the whole population of antibodies in people look like in terms of potency at recognizing this virus. Because again, one of the things that's been seen pretty consistently about these viruses is that people have pretty broad antibody responses. It's not that there's just one antibody that can recognize it. So there are multiple studies on this. I'm going to show a couple really quick. This study by Nussensweig and colleagues is actually using vaccinated individuals, and here's what they observed for the South Africa variant, but it's the same mutations in the Brazil variant. And they showed about a 2-fold reduction in the neutralizing antibody recognition. That's a real change, but it's not a big change. However, 2 reports, both coming from labs in South Africa, have observed more dramatic effects of mutations in their neutralizing antibody assays. Not everybody's assays are identical. Not all the subjects are identical. And in this study by Penny Moore and colleagues, and she's a fantastic scientist in South Africa, has done really good antibody work, about half of the subjects now had undetectable neutralization. So that's more concerning in that paper, because that's a loss of recognition. It's a moving target because there's no perfect assay, but I think the majority of people are looking at this data and saying, well, if you focus on studies of vaccinated individuals, and I'm showing the 3 big ones here, they're mostly reporting modest to moderate changes in recognitions of South Africa variant mutations. So the Nussensweig that I already showed, data from the Moderna and the National Institutes of Health, and then Pfizer, which came out last night. So a 2-fold, 6-fold, or less than a 2-fold. That's a real effect, but most of us would not consider that a big effect. That is consistent with broad antibody diversity in human immune responses again. So yes, these variants are having an effect on antibody escape. And so yes, it does make sense to explore updated vaccines that could recognize it even better, but antibodies are recognizing. And more importantly, as said in the previous slide, your immune system has more than just antibodies. So most of the scientific publications and most of the discussion in the media are about antibodies, and that is because antibodies are important. They're also a lot easier to measure than the other parts of the immune system. So there is just going to be an inherent bias there. And really your immune system has a lot of weapons, not just antibodies. There are memory B cells, but also 2 kinds of T cells. And then all of these can work together for infections depending on the infection. So are these variants likely to escape vaccine-induced immunity? Well, on average, the reduction in neutralizing antibody potence was modest in vaccinated individuals. So that looks mostly okay. 2, even if the virus gets past the antibodies, memory T cells are present in people, in vaccinated or previously infected people. And I don't have time to go into it, but we can go into it later if you want. T cells are associated with protection against COVID in a variety of contexts. And it's quite unlikely that the variants are escaping the T cells. So the T cells are going to probably do good things to control the infection in you. Additionally, memory B cells can make more antibodies, so that's good. But they're also basically a library of variants that your immune system generates to try and counteract any variants the virus would make. And there's good evidence from us and others that people make lots of memory B cells to this virus. And lastly, given the I do think this is fundamental, given the relatively slow kinetics of COVID-19, if the virus gets past the initial antibodies, there's still a lot of time, a lot of opportunities for immune memory to amplify and have an impact. So that's why most of us are still quite optimistic about that. So that's it for my time. And yeah, we can discuss more later.
Perfect. Thank you, Shane. That was great. Food for thought, and actually maybe the most optimistic view I've heard of where we are with the South African and Brazilian variants. Let's bring on the other speakers, and then we'll have a group discussion. The last person I've not yet introduced is Sir Patrick Vallance, and we're really honored to have Sir Patrick with us. He's Chief Scientific Advisor and Head of Science and Engineering for the Government of the United Kingdom. Prior to that role, he was Senior Vice President for Discovery and Development at GlaxoSmithKline. And he's also been in our world. He was a clinical academician, a professor of medicine at University College London prior to these roles. So Patrick, welcome. Thank you for joining us. I know it's late there in the UK, so thank you especially. Let me keep Shane on and actually bring back George as well. And see if George is still around. But while we're doing that, let's start out, Patrick, and just let you, as we in the US would say, riff. Tell us about what's happening in the UK from your point of view, with a particular focus on the variants and what it's meaning and how you're dealing with it.
Sure. Well, first thing to say is that we've passed a rather grim milestone this week of 100,000 deaths since the start of this pandemic, which is obviously, a bad moment and a sad moment. We've got significant outbreaks still in the UK. We've probably got over 1 million people with the disease at the moment. 1 in 55 people, we reckon, have got the disease. Yesterday we saw 1,239 deaths in the last 24 hours recorded. So, we're right in the middle of it. We're in a lockdown. We've got a stay at home for most people, and schools are shut. And that is working. I mean, the rates have flattened off and they're coming down in most places now, not everywhere, but in most places they're coming down. So we feel as though probably we're past the peak of this second wave and on the way down, but quite slowly. We've got a vaccine program which is rolling out. Something like 7.5 million people have been vaccinated now, had a first dose. That's well over 10% of the population, with a high proportion of people over the age of 80 and those elderly people in care homes having been vaccinated, as well as frontline medical staff. And our committee that advises on vaccination and immunization has come up with a priority list of people, and that's being followed quite rigorously across the country to try to get vaccination against really in those people who are most likely to end up with serious illness or who are most exposed to the virus. But to speak a little bit about the variants, we started quite a big sequencing effort in the UK quite early on in the pandemic. Back in April last year, we decided we really needed to have a very substantial sequencing effort to trace outbreaks, look at origins and lineages of a virus. And actually that was quite important for us to understand where we initially got seeded from. And it's worth just reflecting that whilst everyone's attention, including ours, was on China and the East, in the end, most of our seeding in the UK came from France, Spain, and Italy, which we can trace, obviously originally via China, but that's the route by which things ended up in the UK. And we got quite a wide seeding right the way across the country, pretty much simultaneously. But the large sequencing effort called COG UK, a collection of academics pulled together, and the Sanger Centre, has been really important in terms of picking up, obviously, variants. And we've currently, were until very recently anyway, it's a bit less now, sequencing 10% of confirmed tests. And we hope to be sequencing 20,000 sequences per week by the end of February. And so that's been a big effort. We saw a fast moving outbreak in one part of the UK near London just before Christmas in December, and it was growing at a time when everywhere else was shrinking. So we'd just come out of a sort of milder lockdown, and we're back in some form of lockdown, but this area was growing when everywhere else was shrinking. And that really made us look a bit harder at what was going on there. And that's where the variant that Shane has talked about was identified, B117. And what we now know is that variant is the dominant form of COVID in the UK. So it's about sort of, in some places in London, for example, it's 75% of the COVID cases are the new variant. It's got 23 mutations, as has been described. I think the ones that are particularly important are at position 501 and N501Y in the spike protein in the receptor binding domain, which we think may be important in terms of binding affinity and may account for some of the features which I'll mention briefly. But there's also a deletion in position 69 and 70. And that's important because it turns out that the test that we use for PCR detection, the Thermo Fisher test, measures three different sets of primers, one against N, one ORF, and one S. And when you have the deletion in 69 and 70, you lose the S. So in our routine testing, we're able to actually pick up whether the variant is present or whether it's the wild type, because you lose the S positivity. And that's allowed us to get a pretty good handle on the spread of this virus. What we've found is that the virus has an increased transmissibility, and it's difficult to get a really good handle on this, but we think it's somewhere between 30 and 70% more transmissible, or at least it spreads faster. We don't yet know why. And that's being looked at obviously very actively. And then last week, we got the first hints that it might also have an increased severity and an increased mortality signal associated with it as well. When we look in hospital data, we didn't actually see a difference in hospital outcomes. But when we look in one of the testing data streams, we see that people who tested positive for the variant look as though they may have a slightly increased mortality. It's not a very big signal, but we think it may be there, and we're looking at that from different angles. So it's got both increased transmissibility and possibly an increase in a mortality signal. But as Shane described, we do not think now that this has immune escape. So we think that it's largely susceptible to previous infection, antibodies derived from previous infection, from the monoclonals, and also from vaccines. So we think it's got a very good response to standard immune responses to the wild type virus. We have seen some cases of South African variant, small number of cases of South African variant, mainly in travellers who've come from South Africa. We haven't yet seen any cases of the Brazilian variant in the UK, at least the one that was found in Manaus. There are two variants, and one of them we've seen a few cases of, but the Manaus one we have not. So where we are at the moment is we find that with a stricter lockdown, and that now includes, as I said, school closures, we've got decreasing numbers. So, the question that we had is how easy it is to get on top of the new, more transmissible variant. The answer is with a light lockdown, you won't get on top of it. With a heavier lockdown, you do. And that's coming down. And as I say, as we continue to roll out vaccination, we would expect to see a further decrease, especially as we know now that the variant is susceptible to the vaccine. I think I'll stop there, Bob, and leave plenty of time for questions.
Perfect. Thank you. It's scary, but it's good to hear that things may be stabilizing a little bit. What's been the politics of going to a stricter lockdown? There are people accepted it, people resist it. How's that worked out?
Well, nobody likes it, that's for sure. But there's a surprising, I would say that the vast majority of the British public, and we see this in terms of actually prefer the government to take stricter action than not stricter action. So they actually get it and would rather that action was taken in advance and done firmly enough. And if anything, when you look at the surveys, people get more unhappy when the government doesn't go as far as the public thinks they should go. And that's been the theme throughout. Now, is everyone fed up with it now? For sure they are. And, one of the risks, I think, at the moment is with vaccines coming on, everyone thinks that's sort of Liberation Day. And of course, as we know, it's going to take time to get through all the right cohorts of people that need to be vaccinated. The vaccine is going to take time for immunity to develop. And until you get to very high vaccination rates, of course, the rest of the population still remains vulnerable, and quite a big wave of infection could recur. So I think getting that messaging right is a key thing at the moment for us.
And people here have been asking, almost in anticipation, should I change my behavior, sort of independent of what the state says we should do, but should I change my behavior? If I was staying 6 feet apart before, should I stay 9 feet apart? If I was wearing a 1-ply mask, should I wear a 2-ply mask, or should we all go to N95s? How have you approached that in terms of the guidance to people about what they should do independent of the lockdown?
Well, what we haven't done is change things like distance. So, I mean, our rule on distance is 2 meters. And we see no reason to change that, in the sense that that's more based on the physical properties of droplets than it is on virus properties. So those sorts of things we haven't changed. But what we have said is don't change your behavior because you've been vaccinated. You're the same as everybody else in that. And of course, part of the reason for that is we don't yet know the full details of how good the vaccines are at stopping you contracting virus or passing virus on, so you could still be spreading. And until we get more information on that, I think we're going to be pretty cautious, and people, I think, understand that.
Yeah. Let me see if George or Shane have any questions for you, and then we'll kind of open it up.
Fire away, Bob.
Yeah. So I guess one of the things that's interesting is you have been way ahead of us in the UK at looking for these variants. You found it early, and yet it spread like wildfire. In retrospect, was there something that you could have done to contain it, or is it the nature of it being so much more infectious? There's nothing you can do. It's sort of a relevant question for us, as we now know of a few cases where we're screening nowhere near the number of patients that you are. But is it containable, or is just the nature of the beast that once it's there, it's going to grow?
Well, I think we saw this quite early. The genetics team saw it quite early, but of course they didn't know it was spreading more rapidly until more data had come up. And as you know, there are lots of variants, and so I think it was watched for quite a while, by which time it had taken hold, and then it was quite difficult to contain because it spread so quickly. And it actually spread, I think, quite quickly in schools that were open at the time, and they were one of the only things that were open at the time, and so it was obvious that's where they would spread. So I think we had difficulty containing, and I think the experience in Europe, and I think Israel has now got 40% or so of their cases of this variant. I think it's pretty difficult to stop, actually. Yeah. The only thing that we're observing at the moment, we're not yet seeing the sort of spread of the other variants. So the question is whether the UK one actually is particularly good at spreading, even though it doesn't carry the risks, of course, of immune escape. I mean, what would be scary, I guess, is one with immune escape that spread quickly as well. That would be a big problem. But
actually, thank you. I actually wanted to ask that to Shane as well, maybe to George as well. We've sort of gone with the assumption that if the South African or the Brazilian variant enter the United States, it's going to spread like wildfire. And yet, I don't think you said, and I don't think I've heard anybody say, that it necessarily is more infectious. And it's just got this nasty propensity to make potentially to make the vaccine work less well. So is there something about the structural changes that should make it more infectious, or is its real problem going to be potential vaccine resistance rather than it's likely to become the dominant strain? Shane, do you want to try that?
Sure. So they all share this 501 mutation, which is thought to be essentially a primary mutation in the UK variant. So the South Africa and Manaus variants have that same one. So if that's the key to the transmissibility, they've all got it. So that's one option. Additional mutation. So one simple way of viewing the world would be, oh, well, if the virus can bind to its receptor better, it'll be more transmissible. And so it looks like the UK variant binds about 2-fold better. And then the additional mutations in the South Africa and Manaus variant look like it's, at least in one preprint, it's like 100-fold better. So that's a big jump. Now, virology is not that simple. And in fact, the previous variant that swept the globe, the 614, it actually had a somewhat lower affinity for the receptor and yet was more transmissible. So there's not a simplistic relationship that we can depend on. That essentially is the data as it stands right now.
George, as you hear about the UK variant and then hear about the South African and Brazilian variant, does that change your thinking about the recommendations to individuals about what they should do with masks and about policy in terms of, for example, I've heard people say, sure, it was reasonable to open things back up now based on the surge in California coming down, but we have these variants and it's another curveball and maybe it's premature because we could be London in a month. So how do you think about this, with the variants now? We know that they are here.
Yeah, I mean, I tend to, what I'm thinking is we might want to be vaccinating people preferentially in areas where these variants are occurring. And so it's ring vaccination is not quite the right term, but that's what people use. It's a sort of a shorthand of having a single, what protection you can get from a single dose. You might be able to stop some transmission. So I think that I think that might be a strategy with the UK variant. As you know, as we were talking about beforehand, there's the first case of the South African variant that's cropped up in South Carolina today, and one of the Manaus variants has appeared in Minnesota. So those are around as well. But if there ever a time for contact tracing and isolation and sort of old-fashioned stuff, this is it. But I think that the UK variant may be more widely spread. In California, it's heavily concentrated in San Diego County and that sort of eastern tier of cities just to the east of San Diego, like El Cajon and places. So I think that there might be some strategic focus on those areas where this is out to try and get more vaccine into more people. I am curious about, Sir Patrick, if I may ask, when you say schools, what schools are you talking? Primary schools, secondary schools? Because that's a big issue for us.
Yeah, it's a big issue for us as well. And so we've done everything we can to try and keep schools open. And what we did in order to get a sort of stricter lockdown and get control is have to close both primary and secondary schools. So that's children from the age of sort of 5 to 11 and then 11 up to 18. Both sets of schools were closed, and we've got pretty good evidence that you can see a change in the as the schools were closed during the normal holidays and then reopened again. And then as we went into lockdown with schools closed, we saw a clear decrease there. And schools will again be the thing we'll want to open up first when we've got room to do so. So our position from everything we see is that, of course, children are at very much less risk of serious disease from this. We do think that the older children, so the 11 to 18, increasingly look like adults in their spread of the disease and the way it behaves. Younger children less so. And indeed, the spread from younger children to teachers seems to be much less than it is in older schools. And in fact, the biggest spread probably for teachers is teachers to teacher, not children to teacher. So we think, and all the evidence is that we have that teachers are not at increased risk, particularly compared to other professions. But we did see that introduction into the household did come from schools when they were open. We can trace that clearly, and that was often during that period a common reason for introduction into the household. So schools are part of this. Largely, when things are more open, schools seem to reflect community levels, as far as we can see. They're not a particular nidus of infection or a way to spread it, but they are part of the system, and they do add pressure on the R, particularly when you've got readily transmissible variants.
One of our viewers, Sir Patrick, asked anything that the US can learn from the UK's public health response and vice versa. And I also wonder whether anybody from the Biden administration has called you to ask for advice about what are the things you've learned from what you've been dealing with for the last few months.
Well, we have regular calls amongst science advisors from across the world and try and share information as far as we can. I know Eric Lander from previous interactions, so I've been in touch with Eric, and once if he's confirmed, we'll have a proper discussion. All we've done is said hello by email so far, and nothing more than that, because there's nothing we should or could say until he's confirmed. But I think what is there to learn? I think we can all look at where things have become clearer over time, and I think some of the lessons that everyone's learned are when you get outbreaks, you've got to move faster than you think you want to, you've got to move harder than you think you want to, and you've got to go a bit broader geographically than you think you want to. I think are the absolutely key lessons that people have learned. And I think the one thing that, well, maybe I'll pick out 3 things that I think have gone pretty well in terms of the UK situation. I do think getting our sequencing set up early was an important thing to do, and that's been proven to be useful. I think the second thing is that we had a really big effort to get people into clinical trials, and we had a very high percentage of people in hospital who were in clinical trials, and that paid dividends because we got the dexamethasone results early on. We were able to show that hydroxychloroquine and chloroquine didn't work in hospitalized patients. So we've had more didn't works than did works, but that's pretty useful because there's a lot of pressure to use these things, and it's good to be able to show what doesn't work and what does work, and we're getting an increasing number of things that in our look as though they do work. So that's pretty helpful. And the third, I think, was to quite early on get a vaccine system set up to make sure that we knew exactly how we were going to access a portfolio of vaccines, because nobody knew which ones were going to work, or indeed if any of them were going to work. And I think that's worked pretty well. And those are things that I think went well. And then inevitably there are things that haven't gone well, and we're in a difficult situation at the moment. But whenever I speak to science advisor colleagues from governments around the world, we basically all got the same story, same issues to face and the same problems, barring those countries that went for a complete isolation policy very early on.
Yeah. One of the things you have done is change the way vaccines have been allocated, as I understand it, deferring the second dose. Actually, before we go to you on that, can I ask Shane kind of what you, from an immunologic standpoint, this sort of trade-off of giving people the second shot at the quote right time, 21 or 28 days later, versus potentially a trade-off of getting more people to get their first shot sooner? How do you think about that as an immunologist?
There are layers to that. So immunologically, in a variety of immunization situations, actually delaying a booster immunization results in at least as good, if not better, memory over time. So to say, whenever it is you get the second immunization, if you were to look 6 months later, it's going to be at least as good if you delayed it. And there are certainly scenarios where it's better. So immunologically, that's fair game. It is a much more challenging prospect to interpret the Moderna or Pfizer phase 3 clinical trials and extrapolate what does one dose immunization mean. And I think the UK government has made decisions they've had to make under pretty extreme emergency use scenarios, right? So they had to make a decision and they made a decision. I think what was in the clinical trial was that there was some evidence of protective efficacy up to that 1 month, right? Up to the day 21 or 28, depending on whether it was Moderna or Pfizer. And George, I think, briefly summarized that. So I think that signal is real. The big uncertainty is that protection actually sustained out to 3 months, or is it just this transient phenomenon that fades quickly and you really heavily depend on that second immunization? And currently there's no data on that, and there's no real plan to generate that data. And I will say, in addition, when that decision was made, sort of connecting back to a point George brought up, right, is the difference between protection against symptomatic disease versus protection against infection. In the clinical trials, the RNA vaccine clinical trials just measured symptomatic disease for very good reasons. And so people say, well, we don't know about transmission, right, or viral loads. George pointed out the data very rightly in the FDA filing by Moderna that suggests there's an inhibition of, there's a reduction in transmission and infection, and it's a small amount of data, but I think it's reasonable. It's also, from my perspective, pretty unlikely that a vaccine that gives you 95% level protection is not having a big reduction of viral loads and transmission also. And to me, just to wrap this up from my side, I'm actually quite keen on the data coming out of Israel because that's the first population that's been heavily immunized with an RNA vaccine and has been tracked pretty well. And the data from one of those healthcare systems that they showed, pretty compelling graphs from 50,000 people, they had a 60% reduction in cases, right, by day 21, essentially after the first. So that's essentially protection from one immunization. And what's different than the clinical trials is that's PCR positive cases. That's not symptomatic cases. So that's essentially 60% protection from infections per se, which if one dose is giving you that, you're likely to have protection against symptomatic infections for substantially longer than 1 month, because that's a higher bar than just prevention of symptomatic disease. I don't know if all of that.
No, it makes it
Okay.
makes sense. Obviously, a complex question. I wrote an editorial in the Washington Post supportive of this strategy and got a lot of pushback on a variety of things, including the possibility that you're inducing mutations. Is that a real concern that if you wait too long?
It
for the
is,
second-
which is where this issue of if the immunization is not blocking infection, is not significantly reducing viral loads, if it's just reducing symptomology, you're creating a bad situation where you have a lot of people infected, right, with partial immunity. And to me, I mean, it's limited data, but I would interpret the Israeli data as saying that's not the scenario that's occurring, that the vaccines are doing a pretty good job of preventing infections, and then that the immune escape thing becomes a scenario. I think the other sociological aspect, Bob, is if you make a recommendation that doesn't directly follow the phase 3 clinical trial, do you enhance vaccine hesitancy, right? Because you don't. So that's a communication issue that's very much outside the wheelhouse.
And we'd interviewed here Paul Offit, who basically that was his biggest concern, that people are going to hear this and say, maybe I don't need the second dose because they keep changing their minds. So Patrick, maybe take us through the decision. I don't know if you were the final decision maker on that, but how did that decision happen, and how is it, what were the trade-offs you considered, and how's it been going?
Yeah, no, I definitely wasn't the final decision maker on that, and this was driven really out of a public health consideration, and the chief medical officer was absolutely clear about what he thought needed to happen here, which was based on a very simple calculation, which is the number of people you would save by getting more into people's arms, more people injected quickly than having people with double doses, especially when you look at the data from the AstraZeneca and the Pfizer trial, and now the Moderna trial, as has been pointed out, you get pretty good efficacy. So it was based on an assessment. If you look at the Pfizer data, Pfizer-BioNTech data, for example, if you look at after the first sort of 10 or 12 days, when obviously you wouldn't expect to see protection, you then see something like 89 or so % protection for the next period up to 21 days. So I think the decision was made on clear public health grounds and recommendation of the Joint Committee on Vaccine and Immunization that this was the right trade-off to make. And what we need to do is to monitor this very carefully. So one of the things, just like the Israeli data, we need to measure things and see exactly what's happening, and keep looking at this over the next couple of months as we see the effect. But as Shane has said, the Israeli data looks pretty encouraging, actually, and we've had a couple of conversations with them about this as well. So we'll see. And it was a very clear way of trying to get more people vaccinated. And as I said, we're now well above 10% of the population, and 80% or so of people over the age of 80, which I think is key in terms of where the mortality is.
Great. George, what's your take on this controversy, and what do you think the U.S. should do?
I think there's a problem with there's a messaging problem, and I don't think it's I think we have a lot of vaccine, and I think that I mean, if we're giving everybody a first dose, there's no reason, at least my reading of the supply chain is there's no reason we can't give them a second dose and get the messaging right. So I can obviously see it both ways, and if you really are strapped for vaccine, I think giving people the first dose, just the first dose for a while, is fine. But if we have enough, I wouldn't be messing up the messaging.
Got it. Well, moving to the end, maybe let me leave you all with one chance to comment. And if you can sort of, hearing about the variants, I think there's a lot of people that are just bummed out because they feel like otherwise the news in the US is good. We have a new administration that's taking this seriously and putting competent people in place. The vaccine is working, the curves are coming down. And the variants are like, oh God, now this. So what's your overall message to people? And is there something about this that you're actually hopeful about? Or is the message more pessimistic now? Maybe I'll start with George and then end with Patrick.
Well, I'm a sort of half glass, half full type of person. I think we have a race. We have to get the population vaccinated. We have a big bump in Southern California from naturally acquired immunity, where maybe 20% of people living in parts of Los Angeles and the kind of the ringing counties are immune. So that gives us a big bump. We have falling rates. We have a population that's pretty compliant with masking and social distancing. On the other hand, we're going to you have the variants, and we're reopening schools, which could push up the R's. So I think it's, this gets down to the difference between R naught and R sub E, which the British inexplicably call R sub T. But the effect where you get to add in the background population immunity level, and I think that I think we're actually seeing that play out in Southern California, and it may get us far enough down the curve that we can withstand some of these hits from variants.
All right, that's a hopeful piece of way of interpreting it. Even though you managed to ding an entire nation with the chief scientific officer on the line, but we'll go past that. Shane, how are you feeling these days?
No, I mean, I'm with the perspective you put out. I mean, a lot of these conversations I have with people, I say, look, to me, the context is December 1st, we were in a bad spot, but the future looked really good. I mean, the vaccine efficacies looked really good. And so it was looking, and so, yeah, I mean, the additional data about the variants has been, there's definitely a bummer. I guess I would say the job of scientists, right, is to do experiments and look at data and figure out what it actually means, right? And that's, and be relatively impassive about that. And so I do think people have been doing, in aggregate, a really good job of that, and phenomenally fast under incredibly challenging interpretation situations with far less data than scientists would like to have, to make those calls. I do think there are, as I said, I do think there are some risks to particularly the South Africa and Manaus variants, in terms of immune escape. I think the most likely outcome is that the vaccines will be okay against them, but it's definitely worth paying attention to. And I think since it has happened, people keep asking, is it going to keep happening, right? Or are we on just some hamster wheel? And there is uncertainty about that. I'm feeling it's 2021, right? To me, the year started late in January, and I'm definitely trying to look at the data in a reasonably optimistic way. I think it's plausible that the virus has mostly kind of done what it can do, and things are gonna, if we can deal well enough with these variants and outbreaks now, I think and an updated vaccine, I think there's a good chance we're in good shape. But yeah, I'll stop there.
Great. Sir Patrick, I'll leave you the last word. Having lived in the UK for 6 months, I know that people are less sunny and optimistic than people in California. So we'll take that as a given. But go ahead.
Well, I don't forget, I spent 12 years as president of R&D at GSK, and I spent half my life in the States. So I'm used to calibrating these things a little bit. But actually, I'm going to be rather optimistic. We thought for a long time that January and February were going to be the worst months. And I think that's true. We've got a way to go yet. But there is an extraordinary light at the end of the tunnel. I think the whole vaccine story in this disease is miraculous. The speed at which these have come about, the new technologies, particularly the messenger RNA vaccines, but others as well that have come through, and the degree of efficacy we're seeing is an extraordinary achievement, and one that brings great hope, actually. And I think although we've got variants which we worry about, I think also, as Shane said, there's quite a good reason to believe that some of these vaccines are going to be effective and have some effect against those as well. So I'm pretty optimistic that as we go into 2021 a bit more, we're going to see us getting on top of this. But it'll take overall, because this is a global problem, and we need to remember all those countries that can't do the sorts of things we're talking about. There's much more to be done, and I think that's going to last a bit longer. But I think we're on the way out of this.
Great. Well, thank you all for a spectacular session. We learned a ton and really appreciate everyone's perspective. Sir Patrick, particularly for you. Thank you. An honor to have you join us, and I know it's late there. So thank you all for all the work you're doing, and thank you to our, looks like we had about 1,500 viewers in real time, and it'll get posted on YouTube tonight, where typically we'll have tens of thousands more. So here's our crack production team there. Thank to all of them. They make this session work like clockwork every week. Next week will be a regular non-COVID themed Grand Rounds. We'll be back in 2 weeks for another COVID related Grand Rounds. And until then, please stay safe and stay sane, and we'll see you soon. Thanks.